Good morning, everyone. Thank you so much for joining us. It's going to be an exciting presentation today from Dr. Radomski. I'm going to ask Kara to get started. We will start with some usual introductory slides about the group and upcoming presentations, also our summer break, our planned summer break. And then I'm going to introduce our speaker, and I look forward to hearing from him and having a good Q&A at the end with you all. So please prepare your questions, use the chat heavily so we can see what questions are coming up. And I didn't ask Dr. Radomski, but I think we'll wait with the questions to the end. So please put them into the chat, but we will bring them up as we get to the end of the presentation. Kara, would you mind to get us started?
Yeah. Good morning, everyone. Happy Monday. We'll start off with some news and some updates, and then just like Vorshka said, we'll move into our presentation. Just so you know, the meeting recording will be posted on our website, and after we do the introduction slides, I'll have all of these links posted in the chat for you. So I know this is a very busy slide, but I wanted to give you all a heads up that we will be sending out a call for instruments and reviews for the D&I Models in Health web tool. We are looking to expand the new assess section, and we are looking for instruments that are specifically qualitative or mixed methods. Currently, we have over 60 instruments, and so we're looking to build this repository out. So we have built out a submission form, and we will be reviewing the instruments that are submitted through our review process, and then those that make it through that process will be added to the website. We are also asking that you review and rate the existing instruments on the website. So you would just need to create a login. It's free, and then you can go in, and if there's an instrument that you like a lot, or if there's one that you have some extra considerations for, we would love to hear it. And so you are able to submit your feedback directly on the website. So we'll be sending out this call for help in mid-June, but if you would like, you can definitely check out the web tool now. And Vorshka, I see your hands up, so I'll let you chime in.
Thank you so much. So this is our first attempt to send out this call. It's going to be broadly coming to your mailbox, most likely through different sources, but this is our soft launch. So if you have anything in mind, let us know. We are happy to share the link ahead of time. I would like to emphasize what Kara said, that we are interested in qual and mixed methods tools, but we also take quantitative tools. So do not hold back if you have quantitative in mind. We might want to soften that language, Kara, as we are, preparing for this launch to make it clear that we want to see any quantitative, qual, or mixed methods tools to come in. And again, this is through this web tool that we might do a presentation on it later, like next year. But it's one that has been out there. It's in its 11th year of existence. So thanks so much, Kara, for putting this together. And anyone who has ideas, we would love to learn from you.
The next event is the June Disc and InStep Center Seminar. So this is the first part. It's a two-part series that we're going to be doing. And we will have Dr. Rachel Sheff present on her InStep pilot, exploring team implementation factors of vocational training for autistic transition-aged youth. And Dr. Rihanna Platt and Dr. Christina Yuan will be presenting bringing interpreters into the care team, identifying team-based implementation strategies to optimize the role of language access services in child mental health settings. So we typically co-host our DISC seminars with the InStep Children's Mental Health Research Center. We are looking forward to part one of this series. So for our upcoming 2025 AFT meetings, as we usually take a break in summer, so we won't be having any meetings July and August, but we will be returning September 8th with Dr. Jennifer Ridgway. We also have our October meeting with Dr. Kelly Ashbrenner, and November, Dr. Erin Kenzie. And then our December meeting is going to be our typical debrief after the D&I conference, but we will look at the meeting date to make sure it happens after the D&I conference. We are looking for presentations for 2026, which feels just weird to say that we're looking at 2026 now. But if you would like, please submit a nomination request. We've had a lot of really great presentations through the request process. So we are looking forward to our next year of presentations. I will now hand it over to Borshika to introduce our speaker.
Thank you so much, Kara, and thank you again for all your support and participation over the past few months. We are excited to present our last speaker before our summer break, Dr. Tomas Radomski, who is an associate professor of medicine and practicing general internist within the Division of General Internal Medicine at the University of Pittsburgh, and a core faculty within the VA Pittsburgh Center for Health Equity Research and Promotion. He earned his medical degree from the Penn State College of Medicine and completed his internal medicine residency, chief resident year, and general internal medicine fellowship at the University of Pittsburgh and UPMC. Dr. Radomski's research, which has been funded both by NIH and VA, focuses on developing and implementing patient-centered approaches to measure and reduce health services overuse. He has developed and validated a metric to detect low-value prescribing in healthcare data entitled Evaluating Opportunities to Decrease Low-Value Prescribing, or EVOLV-Rx. He is also the principal investigator on a new VA merit grant in which he will conduct a hybrid study to evaluate the effectiveness and implementation of EVOLV-Rx in reducing low-value prescribing among VA nursing home residents. He also serves as the Associate Director of Graduate Programs in Clinical and Translational Science, and directs the TL1 Clinical and Translational Science Fellowship for the University of Pittsburgh Institute for Clinical Research Education. So we are very grateful for his willingness to present today to us, and I will hand this over to him.
Great. Well, thank you all very much for having me today. Good afternoon, I should say, from Pittsburgh in the East Coast. I know morning for you all. And I have to admit, before we get started, I'm a relative newcomer in the D&I space. So I look forward to your questions or comments or any potential tips you might have after you listen to my presentation today. So I'll go ahead and get started. Yeah. All right. So the title of my talk today is entitled EVOLV-Rx VA, Evaluating Opportunities to Decrease Low-Value Prescribing in VA Community Living Centers. And just to start, as was already mentioned, I'm funded by NIH and VA. I don't receive any commercial funding or have any other conflicts. And the content of this presentation does not represent the official views of the Department of Veterans Affairs. So the objectives for my talk today, first, I'll define low-value prescribing, why it's a serious health problem, and the existing research gaps. Next, I'll review the development process for the EVOLV-Rx tool. Next, I'll present the qualitative research findings that inform the development of EVOLV-Rx. I'll then present the results of our Delphi panel and examples of the prescribing practices incorporated into EVOLV-Rx. And then lastly, I'll describe the next steps in incorporating EVOLV-Rx into interventions to decrease low-value prescribing. And that's where I'll talk about my pending VA merit, where we're looking to implement EVOLV-Rx in VA community living centers. And I should say up front, a VA community living center is a VA nursing home. So if you hear me say community living center or CLC, that's what I'm referring to. So let's go ahead and get started. So just to start, what is low value care? It's a term that is thrown out there in health services research, in clinical care as well. But just to make sure that we're all on the same page for what definitions we use for this. And so, broadly speaking, low value care is any health service that confers a risk of harm or cost that exceeds its benefit. And one might ask, why on earth would a clinician, recommend the use of such a service? But unfortunately, we know it happens all the time. And just to provide some additional clarity to what we're really talking about here, another way to define low value care is waste derived from subjecting patients to care that, according to sound science and the patient's own preferences, cannot possibly help them. And what are some examples of that? So you can look at it as care rooted in outmoded habits, supply driven behaviors. So basically, we have the capacity, so we should just do more of a certain test, or ignoring established practices grounded in EVM. And you can see on the figure on this slide that low value care can manifest in a variety of different ways. So it can start with the initial overused service. This can result in downstream low value care services, which we refer to as a low value care cascade. And these both have short and long-term consequences. And these consequences can be physical, psychological, financial in nature. They can also erode trust in the healthcare system. And so when we're conceptualizing value as it relates to a health service, there are a couple different pieces of the puzzle that we think about. First we think about quality, which is defined as the likelihood of benefit or the potential harm to a patient, of receiving a health service. Next, we think about appropriateness. So there's the health service that exists, somewhat generically, but thinking about applying it to the right patient at the right time and in the right context of care. Next, we want to think about service. And in this sense, service refers to the patient experiences, but also making sure that the care that we deliver aligns with their preferences or goals of care. And lastly, we think about cost. And this involves the monetary and the non-monetary costs. So thinking about time costs, just hassles that the patient might experience to receive a certain health service or take a medication. And we can think about cost at the system level, but also at the patient level. So broadly speaking, getting back to that first definition that I mentioned, if a service, the quality, the appropriateness, or the service as it relates to that specific health service is, if that supersedes the cost, then generally speaking, that would be a high value service. In contrast, when the cost supersede these other characteristics in the puzzle, then we think about that as a low value service. And this is a pretty big problem, suffice to say. This figure on the slide is from a report that was done by the National Academy of Medicine that was put out in the early 2010s, where, based upon their estimates and their review of the literature, roughly $765 billion in healthcare spending could be attributed to waste, broadly speaking. And a smaller fraction of that, this $340 billion fraction, could be attributed to low value care, or as they describe here, unnecessary or inefficient health services. So now, why is low value prescribing specifically a problem? So up until this point, when I've been talking about low value care, that could have encompassed tests, procedures, medications, but now drilling down more specifically to low value prescribing. So we know that 30 to 50% of older adults have received a potentially inappropriate medication. And I use the term low value prescribing a lot in my research, which we define as the potentially inappropriate or prolonged use of an unsafe, ineffective, or unnecessarily costly medication. In the geriatric literature, you tend to see potentially inappropriate medication as the term that's commonly used. So the terms have substantial overlap, but just I want to point that out if you're familiar with that PIM term. Also, over 40% of adults age 65 or greater are subject to polypharmacy, so taking 5 or more medications. Many are also subject to hyperpolypharmacy, so taking 10 or more medications, which we know is associated with adverse drug events, hospitalizations, and increased out-of-pocket costs. So moreover, Among Medicare Part D beneficiaries, 35% have reported difficulty in affording their medications. And in particular, with just newer medications that are on the market. So, thinking about certain blood thinners, new medications for diabetes, newer cancer medications, there's just high out of pocket costs for appropriate treatment of common medical problems. So, even if you're not on any low value prescribing practices or receiving those or potentially inappropriate medications, your medications are just going to cost a lot. And low value prescribing has the potential to crowd out those needed medications if you have to make a choice between a medication that the patient might not realize is a low value medication versus others that are evidence based and definitely fall in the bucket of high value prescribing. But that being said, there are several gaps in healthcare value research related to prescribing and deprescribing that in my work, I'm striving to address. So to start, within the low value care world of research, there's really been an emphasis on tests and procedures and not really prescribing, even until this day. So that's a huge gap unto itself. The existing recommendations focus really more on medication safety, but they don't really look at value writ large, thinking about cost, thinking about that service aspect, really focused more on harms, which is very important, but I would argue somewhat incomplete. The measurement tools that do exist, really have not been validated for use in administrative data, really are not been validated, for looking at tests and procedures, either, let alone medications. So this is the major problem when we're thinking about how do we measure low value health services. And to date, the tools that do exist, by and large, exclude patients and practicing clinicians' perspectives. So they're very, very expert driven. But as you can imagine, value is a subjective construct. And so I think it's really important to integrate patients and practicing clinicians' perspectives as best we can. So thinking broadly about, how can we reduce low value care and improve healthcare value? A colleague of mine and we generated a framework, for how we can go about doing this, where we think about balancing more top-down policy prescriptions with bottom-up approaches unique to health systems and practices to reduce low value care. And there are 4 steps here, and the research that I'm going to talk about for the rest of the presentation really centers on steps 1, 3, and 4. So just to briefly walk you through these. So step 1, thinking about developing and applying validated tools to measure low value care. And that's where my EVOLV-Rx tool comes in that I'll talk about in just a moment. Step 2, I'm developing an embedded research agenda to establish de-adoption priorities. And this is something that would be department or health system specific. Step 3, aligning approaches to reduce low value care with the motivations of patients and clinicians at the point of care. And this is something that we really strive to do as part of the development process for EVOLV-Rx. And then step 4, implementing behaviorally informed interventions focused on shared heuristics and combating cognitive biases. And I'll touch upon this a little when I talk about the intervention that we're developing that incorporates EVOLV-Rx. So next, I'll review the development process for the EVOLV-Rx metric. So this work was really part of my K-23 grant from NIA, where our overarching objective was to develop, validate, and apply a metric that will characterize specific low-value prescribing practices using administrative data, and that reflects the perspectives of patients, prescribers, and payers as they relate to healthcare value. And so our first aim for that grant was to develop EVOLV-Rx, and subsequently we sought to validate and apply it. And so here's the overarching process that we undertook to develop the EVOLV-Rx metric. And once again, that stands for evaluating opportunities to decrease low-value prescribing. And just to briefly walk you through all of the steps here that I'll talk about in more detail in just a moment. So we started with a guideline and literature synthesis, looking at the whole host of recommendations that are out there for potentially inappropriate medications, other low-value prescribing practices, whatever the term of art was, for that specific metric, where we categorized greater than 500 existing recommendations that were already out there, as part of other tools. Next, we conducted patient and caregiver focus groups and prescriber interviews to really drill down into their perspective on healthcare value as it relates to prescribing. Synthesizing all of this, that led to 27 candidate low-value prescribing metric practices that we then fed forward to a Delphi panel of international experts in healthcare value, deprescribing, pharmacoepi, also which incorporated some practicing clinicians too, and pharmacists. And then after 3 rounds of an asynchronous Delphi panel that we conducted in conjunction with the RAND Corporation, that led us to our EVOLV-Rx metric. So next, what I'll do is I'll present the qualitative research findings that inform the development of EVOLV-Rx. So this ties into this the patient and caregiver focus groups highlighted here in the red arrow. So we sought to identify the most significant factors that impact the perceived value of a medication from the perspective of patients and caregivers. And we conducted 6 focus groups of patients aged 65 years or greater, or their respective caregivers, and who were prescribed 5 or more medications. We explored their views on factors that enhance or diminish their perception of a medication's value and may motivate their decision to discontinue its use, either in general or secondary to a recommendation from their provider to deprescribe that medication. And we identified 3 key themes: perceived effectiveness, impact on quality of life, and then cost. And so for perceived effectiveness, when a patient or their caregiver was adjudicating the value of a medication, suffice to say, if that medication led to improvement in their symptom burden, objective improvement in any type of clinical value, so a blood pressure reading, a blood sugar reading, or if that medication came from a trusted or was prescribed based upon a trusted prescriber's recommendation, that really enhanced their perception of the value of that medication, and really it would be a medication that they would feel that they would want to stay on or continue, or might be maybe somewhat leery about deprescribing unless they got a good reason to do so. Interestingly, and not surprisingly, I'd say patients tended to weigh improvement in symptoms more, whereas caregivers tended to hang their hat more on objective improvement in clinical values. Next, impact on quality of life. So patients were very concerned about the severity and impact of any medication side effects. They also brought up discomfort associated with administration. So 2 specific examples were any type of injectable medication or having to swallow large pills. That was something that made a lot of sense to me. I wasn't really expecting to come up, but came up very frequently in our focus groups. And also inconvenience related to daily routine. So thinking about having to take a medication on an empty stomach first thing in the morning, or that you had to sit upright for 30 minutes after taking a medication, which you have to do for some medications for osteoporosis. So these were all factors that would diminish the value of a medication. And if a clinician told the patient that I think you should stop this medication, they would be much more willing to do so, if there were more severe side effects, inconvenience, those types of things. And here's just one quote. This was from a caregiver. So I'm thinking about my grandfather's situation. If his sugar stays too high, then he will not heal, and that's how he lost 1 foot. So he has to take his sugar. It's very worth it. So that little bit of discomfort for him, well, you could take that. And this just gets at some of the divide that we saw, between patients and caregivers, where the patient may not appreciate that discomfort, but the caregiver, is focused more on the objective values, the blood sugar readings in this case, that they're able to follow related to that medication. And then lastly, cost. This did not come up as much as we maybe thought it would, but the way it came up was less absolute out-of-pocket cost and more the need to make subsequent material sacrifices because of the cost of that medication. And so an absolute higher cost, if the patient could absorb that, if the medication seemed otherwise of value or appropriate to them, there was a willingness to do that. But once it got to the point where it crowded out other things, then that really weighed on them. and would be a medication they might stop taking or would be happy if they were told that it could be deprescribed. So next, I'll talk about the prescriber interviews that we did and the findings from those. So we sought through our prescriber interviews to identify the characteristics that affect the value of a medication and those factors influencing low-value prescribing from the perspective of primary care physicians. And we conducted 16 semi-structured interviews of primary care providers who care for adults aged 65 years or greater. And this included general internists, family medicine physicians, and geriatricians. And we sought to understand from their perspective the characteristics and examples of low-value prescribing in older adults, the factors that incentivize them to engage in such prescribing, and any interventions from their perspective that would make them less likely to engage in low-value prescribing. And once again, we identified 3 key themes. So the first was that from the prescriber's perspective, low-value prescribing is common. In fact, they referred to it as almost a default practice in clinical care, and that any interventions to address low-value prescribing, must address underlying drivers, which I'll talk about in just a second. So first, low-value prescribing being common. They highlighted a number of medication and patient-level factors that might influence the value of a medication. So thinking about a patient's medical comorbidities, their overall state of health, and whether they have and experience any frailty. Also medication factors, so thinking about medications that might be overly sedating or might result in nausea as a side effect, just 2 examples. And between all the different clinicians that we interviewed, they brought up 43 different medications or medication classes that in certain contexts could potentially be low value. And they also brought up the concern for cost, that prescribing a costly medication to a patient, they were concerned about how that would influence the value of that medication to the patient. In terms of low-value prescribing being a default practice, the providers that we interviewed, really thought that low-value prescribing was driven by a variety of patient, provider, and health system level factors. And just 2 examples of these were patient requests for potentially low-value medication. So you can imagine maybe an opioid pain medication or an anti-anxiety medication that, while helpful to the patient, might come with a number of side effects. And also deference to subspecialists. So kind of this idea that even though the primary care physician is often thought of as the quarterback of the team, so to speak, there was a concern about stepping on toes or not wanting to stop a medication if a subspecialist prescribed it for a patient. Also, just a note about misaligned quality incentives and then also automatic refills. So they might be getting pop-up alerts to prescribe patients aspirin, even though they feel aspirin wouldn't be appropriate, for that patient. Or medications that they thought were stopped might be getting automatically refilled by the pharmacy. And so the patient will continue on a medication longer than they wanted them to be on that medication. And here's just one quote. So the outpatient environment is very busy, and there are so many things to talk about in an office visit that going through the medications and really trying to figure out if something is low value for the patient, that sometimes doesn't make it to my to-do list for that office visit. And this just highlights the importance of time or the lack thereof. That's a substantial barrier to just deep prescribing in everyday clinical practice. And so lastly, the providers that we interviewed really thought that any interventions that we were looking to develop must address these underlying drivers that they highlighted. So 3 points that came up repeatedly. So engagement of multidisciplinary teams. So making sure that it wasn't just the primary physician for the patient that was responsible for all this, thinking about how can we incorporate clinical pharmacists or nurses, improved utilization of the electronic medical record. Is there a way we can incorporate some type of tool or maybe some type of nudge, thinking about the behavioral economic space that could influence prescribing behavior in a way that's not overwhelming and results in alert fatigue, as is so often the case with the EMR. And then lastly, enhanced targeting of value-based incentives. If low-value prescribing or conversely, the delivery of certain high-value care is something that we measure as part of our routine quality metrics, then perhaps we would see more of a focus on this. Of course, the caveat is that many things are already measured, so perhaps other things might need to go in place of some newer value-oriented metrics. So just to summarize our qualitative findings, so patients apply a multifaceted approach when adjudicating the value of their medications and are open to deprescribing when it aligns with these values. Low-value prescribing is a well-recognized default practice by physicians, and that successful interventions to address low-value prescribing must not only consider physicians' perspectives, but also the patient, prescriber, and health system factors that make low-value prescribing common. So these findings really set the stage for the subsequent development of the EVOLV-Rx tool, and also really entered into our thinking as we developed our VA grant proposal for the EVOLV-Rx intervention. And I'll talk about that in the fourth and fifth objectives of my talk here. So now I'll move on to present the results of our Delphi panel and examples of some of the prescribing practices incorporated into EVOLV-Rx. So moving on now to talk about the candidate low-value prescribing practices in our Delphi panel. So we incorporated 27 candidate low-value prescribing metrics or practices, as candidates, into EVOLV-Rx that the Delphi panel would consider. And this was based upon our synthesis of existing tools and the literature, and also the findings from our focus groups and our semi-structured interviews. What we did then is we focused on the top 50 medications most prescribed or costly in Medicare Part D. And we used that to filter the hundreds of recommendations that we looked at as part of our synthesis to really just drill down to those that would be most pertinent to the older adult population. And then we categorize these candidate low-value prescribing practices based upon the following value domains. So lack of efficacy, potential for harm, excessive cost, or could the medication be part of a prescribing cascade where the use of one low-value medication results in the use of another low-value medication to treat a side effect. And one feature of our metric that I'd like to highlight is that each candidate metric was defined by sensitive and specific criteria. And the reason we did this was threefold. So it allows for the incorporation of guidelines from multiple sources. It establishes a range of potential low-value prescribing. And it also enhances the versatility of EVOLV-Rx when used for research or applied in clinical practice. And so what do I mean by the sensitive and specific criteria? So our sensitive criteria, relatively speaking, is more sensitive and less specific. And this seeks to identify those older adults subject to any type of potential low-value prescribing practice for that medication of interest. And our specific criteria, that further identifies the subset of older adults who satisfy the sensitive criteria and in whom the potential for harms or costs are most likely to outweigh any benefits. So each candidate low-value prescribing metric incorporated into EVOLV-Rx may have additional specific criteria based upon the following low-value domains that I list here. So lack of efficacy, potential for harm, or excessive cost. And so here's a specific example of this. So one of our components of EVOLV-Rx is prolonged use of proton pump inhibitors. These are medications that are very commonly prescribed for acid reflux or GERD, gastroesophageal reflux disease, but are often overused and continued indefinitely, even when a trial period of that medication has long since passed. And so our base criteria was PPI use for greater than 2 consecutive months. So 2 months is the standard course of treatment if someone is taking a PPI for GERD or acid reflux. But many patients continue it long beyond that. So anyone that took it for longer than that, we wanted to flag as part of our sensitive criterion, broadly speaking, as someone who might be subject to potential low-value prescribing. But there are some people who long-term use, would be warranted for a PPI. And so our specific criteria drills down even further. So using administrative data, we look for, is there any guideline concordant indication for prolonged use? So for example, a Barrett's esophagus is one condition where long-term use would be appropriate. No concurrent use of chronic NSAIDs. So if you're on a non-steroidal anti-inflammatory drug, prolonged use of a PPI could also be appropriate. So we wanted to make sure that those patients weren't on an NSAID. And also use of a brand name PPI. And this gets at cost and just realizing that a generic is almost always appropriate in these instances. So this is just an example of what we fed forward to our Delphi panel for each of the 27 candidate low-value prescribing practices. And I don't expect you to take in everything on this slide, but just to show you that we put together a nice infographic where we defined the sensitive and specific criteria. We provided a brief synopsis of the evidence. We looked at cost and use data, current guidelines, recommendations for appropriate use. We shared the stakeholder perspectives with them from patients and caregivers and practicing prescribers, and also provided some references. So now getting to the metric development. So as I already mentioned, we did a Delphi panel in conjunction with RAND. It was asynchronous, and this was even before COVID, or actually right at the start of COVID. So thankfully we had planned to do this asynchronously anyways. And it had 3 rounds. There was an initial review of the infographics that I provided, and then a rating. Round 2 was asynchronous deliberation about the practices, and then round 3 was a final review where the panelists codified their rankings for all the, I should say, ratings for all the candidate low-value prescribing practices. And so, we were very fortunate to have 15 Delphi panelists, and then also other members of the research team, really from throughout the United States, but also Canada and Australia, who could lend their expertise in the development of EVOLV-Rx. And so just to highlight the Delphi panel process in somewhat more detail, I already mentioned that we did this in conjunction with RAND, applying the Expert Lens platform. Each round lasted 1 to 2 weeks, and these are the 3 elements that I already described. And specifically, the Delphi panelists rated the scientific validity and clinical usefulness of each of the 27 candidate low-value prescribing practices using a 9-point Likert scale. And following RAND's methodology, candidate metrics where there was agreement and that received median scores of greater than or equal to 6.5 were included in the final EVOLV-Rx metric. And so how did we do? So starting in round 1, of the 27 candidates, 19 had a median rating of greater than 6.5 for scientific validity, with an interquartile range of 7 to 9. 10 had an interquartile range of 7 to 9. So what that means is that even though 19 passed RAND's test, there was still, some disagreement, with, amongst 9 of those, recognizing that 10 really only had an interquartile range, that of 7 to 9. So we really wanted to maximize agreement, and get as high a rating as possible for, for as many of these components of EVOLV-Rx as we could. Next, looking at usefulness in clinical practice, we saw a similar pattern where there was a median rating of greater than 6.5 for 20, but an interquartile range of 7 to 9 for just 11 of them. So we felt like we had a little bit more work to do to refine these practices, or refine our definitions of these practices, I should say. So after round 2 deliberations, we made revisions or clarifications to 19 of the low-value prescribing practices. And what we saw here was that we were able to bring up our numbers. And so there were ultimately 18 low-value prescribing practices, that met our criteria with a median rating of 6.5 or greater for both scientific validity and usefulness in clinical practice. And those 19 ultimately comprised the final version of EVOLV-Rx. And here's what made the final cut. Just to touch on a few of the components of EVOLV-Rx. So starting at the top, thinking about ineffective use, so thyroid hormone for subclinical hypothyroidism, testosterone for non-specific aging symptoms, prolonged use of a whole host of medications, so proton pump inhibitors, NSAID, nonsteroidal anti-inflammatory drugs, inappropriate use of a variety of medications, potentially unsafe use of medications like benzodiazepines and skeletal muscle relaxants, and then overly intensive treatment of two conditions in particular, type 2 diabetes and COPD. So there's certainly things in EVOLV-Rx, that overlap with other lists, such as the Beers criteria, for example. But there are also components of EVOLV-Rx that are somewhat newer and novel relative to other pre-existing tools. Just to give you a flavor of what we didn't include in EVOLV-Rx, and a lot of this was either because the panelists felt that the verdict was just still out, and these medications just weren't ready for prime time in terms of how exactly we would measure them, or that there was a concern that they just would not be practical to apply in clinical practice. So, for example, opioids for the treatment of non-cancer pain, opioid prescribing is just so nuanced. There was concern about, how could you possibly apply, some type of measure that you say is or isn't low value for that. Also, statins for primary prevention of atherosclerotic cardiovascular disease. There was, at the time, there was an ongoing study that the Delphi panelists felt that it was just too soon to work that into the metric for a certain age group where we would say that statins were inappropriate or low value. So just to highlight a few other limitations. So the low value prescribing practices contained in EVOLV-Rx, suffice to say, are not exhaustive. We only really incorporate 18 that focus mostly broadly on medication classes, some on specific medications, but there are still many other recommendations out there, although we tried to capture the most salient ones according to our experts. The infographics that we provided to the panelists were not each based on a genuine systematic review of the literature, and that just really came down to the resources that we had available, although we did incorporate pre-existing systematic reviews into our synopsis that we provided. And the individual components of EVOLV-Rx were sensitive to the composition of the Delphi panel. So I think that's a pretty standard limitation of Delphi panels, where things could have looked differently had we brought on different experts, but nevertheless, these were the things that we found through this process. So lastly, I'll describe the next steps in incorporating EVOLV-Rx into interventions to decrease low-value prescribing. So where do we go from here? And pivoting now to the VA and the intervention that's currently pending. So low-value prescribing affects nearly 1 in 3 VA-enrolled veterans, including greater than 50% of veterans residing in a community living center. And this was preliminary data that we generated for our grant applying the EVOLV-Rx metric in VA. And we felt that CLCs, the community living centers, really represent an ideal setting to fully account for and safely reduce low-value prescribing for any number of reasons. There are a number of pre-existing tools that we could leverage in CLCs. Medication use is also very carefully tracked with barcode medication administration data. And there's really a full clinical team that takes care of CLC patients, not just the primary CLC physician, but you have clinical pharmacists, for example, is just one other element of the team. So really being able to leverage that multidisciplinary approach, thinking about the findings we found from our qualitative work. Also, there's really no intervention to broadly reduce low-value prescribing that had been integrated into routine care and implemented at scale across CLCs. This is not to say that there aren't other initiatives that have been pursued. So Vione, is a great example of a deprescribing approach in VA, but it's not something that's necessarily been mandated across all CLCs or readily adopted. In particular, in our VISN, our VA region, in the Pennsylvania and surrounding states. And so our study objective was to conduct a hybrid study to assess the effectiveness and implementation of an EVOLV-Rx-based intervention to reduce low-value prescribing among older veterans who reside in community living centers in Veterans Integrated Service Network 4. And of course, this ties into VA's long-term goal, which really is to optimize older veterans' medication use by reducing low-value prescribing as part of their age-friendly health system initiative. So the specific aims for this study will finalize the adaptable elements of an implementation playbook for the EVOLV-Rx intervention to reduce low-value prescribing for older veterans residing in CLCs. Next, we'll assess the effectiveness of the EVOLV-Rx intervention to reduce low-value prescribing. And then we'll evaluate and ideally iteratively improve the implementation of the EVOLV-Rx intervention. So specifically, our intervention, we envision is automated low-value prescribing detection and monitoring that incorporates EVOLV-Rx using the Theradoc clinical decision support tool. And this is one of those tools that's integrated into the CLC infrastructure across more than half of CLCs in the country that clinical pharmacists already use as part of their day-to-day in monitoring antibiotics and anticoagulation for veterans. So we thought this was a great tool to leverage. This intervention will be integrated into the 30-day medication regimen review that's already conducted by pharmacists. Up until now, this review has really been more of a formality and not really looked upon as a juncture for potential deprescribing low-value medications. But we hope, of course, that changes as part of this intervention. And this intervention will be complemented with an implementation playbook that we envision containing core implementation strategies, in addition to additional strategies that might be employed and tailored to the intervention to each CLC. And just to give you a sense of the evidence-based implementation strategies that we're looking at to support early adoption and implementation. So we're thinking about external facilitation, using clinical champions, an audit and feedback approach, and then also establishing a learning collaborative. And this is all held together by the PRISM model, which we thought considering its integration with REAIM really was the ideal model to think about how can we finalize and refine adaptable elements of this EVOLV-Rx intervention in the first aim of our grant, taking into account the factors you see here on this model, and also the perspectives of all our key partners. So thinking about what patients, what caregivers, what clinical leaders, what clinicians think about our intervention, thinking about the external environment, the implementation infrastructure, and we plan to conduct focus groups to get at that. But then also using the REAIM model to assess effectiveness and the implementation of our intervention. So just to give you a flavor of some of our outcomes, so thinking about effectiveness, so we're going to be looking at the count of low-value prescribing practices per 100 veterans. We'll be looking at the percentage of veterans subject to polypharmacy and hyperpolypharmacy. We'll be looking at adverse drug events and adverse drug withdrawal events, and also hospitalizations and ED visits. From an implementation standpoint, we'll be looking at reach, adoption, and then barriers and facilitators to implementation, which we'll look at through semi-structured interviews. Reach we're defining as the number and percent of veterans for whom our EVOLV-Rx dashboard is used during their CLC medication regimen review. And adoption we're defining as the number and percent and frequency with which VA pharmacists access the EVOLV-Rx dashboard as part of the CLC medication regimen review. And I should mention, I didn't already mention this, but we'll be applying a stepped wedge design in terms of how we actually implement and study the intervention. So for our embedded process evaluation, we'll be looking to conduct monthly 1-hour meetings with each CLC champion during the implementation phase of each step of the intervention. So we have 5 total CLCs for 3 different steps, one of which will have 1 CLC, and we'll be randomly selecting the CLCs for each step based upon a variety of characteristics. We'll be reflecting on our progress, documenting the execution of and adaptations to local implementation processes, troubleshooting any barriers, and also looking to establish a maintenance plan as part of those monthly meetings. And I imagine the framework that we're looking to apply is pretty familiar to most of you in this group, as this framework has been applied in a number of other VA implementation studies. Just to give you a sense of what our timeline looks like for this intervention. So for the remainder of this year and into next year, we'll be looking to get things started. We'll be conducting our AIM-1 focus groups to finalize the intervention and implementation plan. Then in 2026 and 2027, over the course of a year, we'll be conducting the intervention with a stepped wedge rollout and doing our embedded process evaluation as part of that. And then after that, we'll be concluding the intervention, analyzing our data, and conducting our semi-structured interviews to look at barriers and facilitators to the conduct of the intervention, but also thinking about things to consider as we look to scale the intervention beyond our vision in the future. So in summary, low-value prescribing and polypharmacy are common, affecting up to 50% of older adults in general, but also certainly within the VA healthcare system. Patients are open to deprescribing that aligns with their values, but successful deprescribing is often limited by patient, prescriber, and health system factors. And EVOLV-Rx represents a scalable and patient-centered tool to detect low-value prescribing, which we'll soon be using to study this for the first time in VA-CLCs, as a way to deprescribe low-value medications. Here's just a listing of all of my research mentors, collaborators, and funders that I'd want to acknowledge in conducting this work. And I'm happy to answer any questions. So thank you very much.
Thank you so much. Super comprehensive. Really enjoyed hearing the work and the different methodologies that you brought together in building up toward the merit and now during the merit. I also appreciated you using theoretical basis for guiding the merit work. So really enjoyed the full presentation. Most of us here will not be focused on this specific topic. I will open it up for questions, but I thought you could start with kind of summarizing perhaps, and this is going to be a big ask, in 3, points. What would be some methodological learnings that you had so far that you recommend others consider as they do implementation type of work? So based on what you have done, the types of interviews, the questions, who you included, etc., do you have some recommendation for those of us who are not working in the field, but the methods would apply to us?
Yeah, sure. So just some considerations that immediately come to mind. I would say just the importance when doing any type of upfront qualitative work, to engage as the greatest variety of partners or stakeholders, whichever term one prefers. I think that's really key, because we really did see contrasting opinions, and I think that if you only interviewed one type of individual that might be affected by the intervention, and you really anchored to that, you could really have quite a few blind spots to other considerations, and even thinking just patients versus caregivers. I think that's another point I would say too. In thinking about any type of intervention in the older adult population, in particular the nursing home setting. Even though the medications are administered by the nurses and written by the physicians there, caregivers still play a huge role, and getting their buy-in and sign off on anything is really key, because if something raises a red flag to a caregiver, that can just immediately pump the brakes on something. And anything, I think I'll say too, just on this specific topic of de-implementation. We think there's obviously there's so much work on implementation, whereas de-implementation is somewhat of a murkier area. I would say, and I think there is just even conceptually, thinking, how do you think about it? Are we de-implementing a service? Are we implementing an intervention to de-implement a service? It can kind of get very very murky in terms of how we think about it, but just also the importance of considering a broad base of perspectives when thinking about de-implementation in particular, because there really is that concern about rationing and denying care, and especially in a federal healthcare system, where that can have political implications as well. And so, but at the same time, though, this topic of deprescribing, it's, just anecdotally, people talk about all the time, oh, my grandmother, my mom is on way too many medications. And so there's a lot of buy-in in the abstract for this topic, but how do you take that abstract buy-in and really translate that into something that you can operationalize and implement, and really getting maximum input on that, I think is really important.
Those are fantastic. Thank you for
Mhm.
distilling them in a very short notice. How about others? What questions you might have? Please feel free to unmute and just ask your questions live if you are in a good position.
Okay, so I see a comment here in the chat.
Yeah.
Let's see, most low value care is rooted in health system factors. In my intervention, heavy cardiology field, profit oriented healthcare system is probably the root cause of low value care. Okay. So this is, yes, this is the elephant in the room. And I think what's really interesting though is we've studied low value care delivered in Medicare, but also of course within VA, looking at low value tests and procedures. And even within VA, we still see a decent amount of low value care. We do, amongst beneficiaries of VA and Medicare, we see a lot more in Medicare. So I think that makes sense in terms of more of the fee for service drive, and also kind of the medical legal considerations as well. I have to do this or else I'll get sued. But the low value care kind of concept, we feel and we have observed, has really just permeated the culture, even when fee for service is not really an issue in a system, such as VA. So my view is, the best way to address this, is via interventions that take advantage of more behavioral economic principles, and can nudge providers to engage care in a certain way that is still guideline concordant and evidence based, but eliminates, some of the low hanging fruit in terms of low value care that's delivered. So I'll give you an example of this. In the UPMC healthcare system, for older women with breast cancer, there's recent guidelines that would suggest, women with certain phenotypes of breast cancer do not need to undergo a lymph node biopsy or any type of axillary dissection, but it was still happening at a high rate for those patients, due to a concern that we didn't want to, we were just afraid to stop doing this. We've been doing it forever. In the electronic health record, in the scheduling screen that every physician or nurse practitioner sees when they go into the patient, we inserted a column that just included a flag. All it said, and the flag just meant this was a patient that would be suitable to exclude sentinel lymph node biopsy based upon certain characteristics, and just encourage the clinician to have a discussion about it with the patient. That was it. Very low cost, nothing heavy handed. And we saw a decrease of absolute decrease of 26% in the sentinel lymph node biopsies, just from that nudge, from that prompt. Another good example is looking at standard order sets that are out there and making sure that everything in the order set is appropriate and there's nothing excessive. Studies have shown that can reduce a lot of low value care as well. So there are ways that we can influence decision making that to me seems to be the way to go, based upon the emerging evidence that's out there for both the study that we did, but also other low value services.
Unfortunately, we are at the top of the hour, so we will not take any more questions. But is it okay for me to say, Tom, to people to contact you? I don't know if you had an email address.
Absolutely.
Drop it in the chat. Lots
Yep.
of questions I also had that, perhaps another time we will get a chance to discuss. But thank you so much for such amazing presentation. I had written a number of notes for myself, for my own work. I also wanted to thank everyone for being here and look forward to seeing you again in September. So thank you,
Great.
and happy summer
Yep.
to all.
Yep. Thank you
you.
very much for having me. Take care.
Thank you. Bye-bye.